So I thought for the CPD this evening we could just talk about head injury. It's more just to notice concussion on the pitch itself, a bit about quick assessment on the pitch, and a bit what we do afterwards really to get the player back to fitness from there. If you just want to click pattern. Yes. So the main thing to note is that always stick to the ABCD rule that we all know. We have to stick to that as well. Airway, breathing, circulation and so on. Don't forget that. I know you're assessing a head injury, but this comes into play. It's super important, and this will guide you calmly through the procedure as well. So I think the question is, what is concussion exactly? You know, we all sort of think we know what it is, and we see it the whole time. We've seen loads of head injuries with it. But I think a good definition is injury to the brain resulting in disturbance of brain function. I think disturbance of brain function is key here. So it can come from direct blow to the head itself, or I think, don't forget this one, blow to another part of the body causing results in rapid head movement. So sort of like a whiplash injury, and that can cause a bit of the concussion as well from there. Symptoms can appear immediately, but also don't forget onset can be delayed and occur at any time after the initial injury. I think this is a key point here, that loss of consciousness only really occurs in less than 10% of concussions, so don't expect the player to be knocked out when you get to them straight away from there. So I think you can break it down into three categories about concussions. So there's symptoms, so somatic symptoms such as a headache, cognitive symptoms such as feeling in a fog and a bit hazy, and emotional symptoms where they become a bit labile after, a bit sort of slow and groggy. Then the physical signs, there's quite a few here, so loss of consciousness, impaired conscious state, altered level of consciousness, poor coordination or balance, gait unsteadiness and loss of balance, concussive convulsion or seizuring or tonic posture where their arms are extended and the wrists are flexed, slow to answer questions or follow directions, easy distracted with poor concentration again, nausea, a bit of vomiting, vacant stare, glassy-eyed, slurred speech, and double vision. So just quite a few there, but things you should be aware of approaching the player who's had a head injury, and a slow reaction time is another one there. Then behavioural change I think is key in this as well. You should know your player quite well, so notice, does their personality change when they get head injury, inappropriate playing behaviour, running the right direction, I have seen that where players run the wrong way, and irritability. They're quite aggressive, can be quite combative at times as well. And inappropriate emotion, are they laughing, are they crying? They can get emotional with head injury itself. So I've showed this slide before, and I think it's just to know that there's a lot going on during a game, a lot of distracting factors with the crowd, the noise, a lot going on, but you must watch off the ball and on the ball as well throughout that at all times. So just quickly, when you go on the pitch itself, first man there, Mills, manual inline stabilisation, call the trauma handshake. First on the scene, it's like a protection and a red flag, so you're in control, no one gets around you, and don't cover the ears. It can be quite scary when you cover the ears and the player can't hear what's going on from there. So don't forget, unresponsive players are at risk of losing their airway. Important to do the jaw thrust if you think airway is compromised. Observe the breathing. I put log rolling in just in case the player's about to vomit when they're strapped up. Roll them properly so you can get the vomit out on the side, so they don't aspirate or choke. So potential scenarios, I think there are 4 big ones that you should be aware of. So unconfirmed transient loss of consciousness, I'll talk about each one briefly after. Unconfirmed minor head injury where it's suspected concussion. Witness transient loss of consciousness, and a persistent loss of consciousness as well. So if you've got the unconfirmed transient loss of consciousness, try and see if there has been influences your decision making about what happens next. On-field assessment, we follow the FO head injury protocol, and modified matrix questions are crucial at this point when you do the initial assessment. So witness transient loss of consciousness. Witness, you've got no excuses, you've seen it, you should be on it straight away, know what's going on. Head injury protocol should come straight into play, no messing around. Mills, ABC, escort from the pitch with 2 people, stepwise approach to standing of the players down, and do not leave unsupervised at any point if you're worried about this. Persistent loss of consciousness, and this is worrying obviously, so ABCD straight away into play. Mills must be maintained until full spinal immobilisation. Never lose control of the head, that's crucial. Oxygen at 50 metres per minute via non-rebreathe mask, and never remove the collar until we're completely certain everything's clear from there. Unconscious head injuries cannot support their own airway and may have a serious neck injury. Just keep that in mind at all times. So not everything can be seen, you need to be aware of that. If you miss something, hopefully your team with you can spot it as well. Work as a team to witness injuries. Observe the players at all times and follow the head injury protocol. So signs of severe head injury or facial injury, which you should be aware of, which needs to go straight to hospital. Depressed skull fracture, so palpable swelling or depression, Base of skull fractures are clear fluid, panda eyes, which is black eyes basically, or battle sign, which is bruising of the mastoid area. Open skull fracture, intracerebral events, so behaviour, falling GCS, pupil dilatation. Facial fractures with swelling, numbness, respiratory difficulties, abnormal eye movements. And orbital trauma, loss of vision, abnormal reflex, hyphema and flashing lights. Hyphema is a blood level in the eye itself. Laceration more than 5 centimetres, I think needs to go to hospital straight away from there as well. So just a quick, I mean this is what, on the ATMIF course, what FA follows as well. It's sort of a graded return to play, and just, it's quite a nice one to go through exercise that allowed in stage 1 up to stage 6. The maximum heart rate, duration in minutes that they should go through each stage, and objective what you're trying to get before you get returned to play. Obviously if you can't complete a stage, don't go on to the next stage from there. And then this is just showing you, you know, what for adults and under 19 players, what you should be hitting at staging. This can't be used to anyone under 16, so be aware of that. And I think that's important for reading it. It's the latest consensus statement of concussion in sport. And yes, there's still a lot of queries regarding concussion, but it gives you good guidelines to follow on that from there.